Cognitive processing therapy, rape-related PTSD. Around 50% of PTSD cases in the United States are developed in the aftermath of sexual or physical violence. For survivors of sexual assault, the odds of developing PTSD are high. Up to 94% experience symptoms during the first 2 weeks after the incident, and up to 50% may struggle long term. Only 16 to 38% of rape victims report the rape to law enforcement, and only 17 to 43% present for medical evaluation after rape. Psychologists find that cognitive processing therapy, which helps people learn to challenge and change their beliefs related to trauma, can help heal the mental health problems some experience after a sexual assault. The goal of CPT is to help integrate the rape by processing emotions and confronting cognitive distortions and maladaptive beliefs concerning the rape. Studies of the factors related to police reporting reveal that victims were more likely to report if they were assaulted by a stranger, if they had visible injuries that could corroborate their allegations of forced sexual intercourse, or if the offender used a weapon or physical force. They were less likely to report if they were drinking or using drugs at the time of the incident, or if they knew the offender in any way. In law enforcement, we would always say that victims of rape have a tendency to report only what we would call dead bang cases. Victims, in other words, report the crime to the police when they believe the probability of conviction is high. The assessment of convictability may be arrived at independently or as a result of interactions with criminal justice personnel who imply that the victim's character, reputation, or behavior at the time of the incident are questionable. Victim blaming by both men and women is also an attempt to feel in control of our lives. That piling on of culpability has a devastating consequence. It becomes a secondary victimization that prevents survivors from seeking help, leaving the door wide open for distress to morph into PTSD. The statute of limitations varies state by state. In some, it's as short as 3 years. In others, a rapist can be charged any time. Feelings of helplessness can intensify if, at any point, a victim decides to go to trial. DNA evidence can make or break a case, but it's not a slam dunk. Rapists often claim that sex was consensual, which once again places the woman under a microscope. With or without forensic evidence, a victim must recount her assault over and over in graphic detail. On the stand, she may be ruthlessly cross-examined by the rapist's attorney. CPT is an effective treatment for reducing PTSD and depression symptoms following interpersonal victimization, including physical and sexual assault. CPT can be conducted in individual or group format and completed in 12 weekly sessions. CPT focuses on education of PTSD symptoms, effect of traumatic events, connections between trauma-related thoughts, feelings, and behaviors, remembering the traumatic event and experiencing the emotions associated with it, ability to challenge maladaptive thoughts about the trauma, reduction of negative thinking patterns and motivation to learn new, healthier ways of thinking, exploration of how core themes have been impacted by trauma. Recovery is about learning better ways of coping with trauma and letting go of fear, even fear of change. Slow growth is good growth. The aim of CPT is to stop the client assimilating the event, but rather changing their schema to accommodate the event without over accommodating. The therapist's goal is to help the client accept that the event happened, experience the emotions of the event, and to accommodate this event into existing beliefs. There are links to a couple of guides to CPT sessions and a CPTA session summary and handout guide for your convenience. While all survivors react differently, survivors of sexual trauma may have severe and chronic symptoms of PTSD. Emotional avoidance, such as staying away from reminders of trauma and resisting conversations about what happened. Intrusive symptoms like repeated unwanted memories of the event, recurrent nightmares, flashbacks. Increased arousal, for instance, trouble falling or staying asleep, being easily startled or fearful, trouble concentrating, hypervigilance to surroundings and potential threats to safety, and changes in thoughts and feelings, ongoing distorted beliefs about yourself or others, recurrent feelings of fear, horror, anger, guilt, shame, or hopelessness, loss of interest in once enjoyable activities, feeling detached from others, or struggling to maintain close relationships, difficulty experience positive feelings like joy or satisfaction. One promising tool that can aid providers in these efforts is the SAVE method. S. Screen all of your patients for sexual violence. A. Ask direct questions in a non-judgmental way. V. Validate your patient's response. E. Evaluate, educate, and make referrals. On this slide, I have listed comprehensive, standardized sexual assault assessment tools. And at the bottom, I have a link to Assessing Clients for Sexual Violence Guide, which can come in very handy because this gives a detailed list of what needs to be done to handle assessing victims of sexual assault. The goal of CPT is to help integrate the rape by processing emotions and confronting cognitive distortions and maladaptive beliefs concerning the rape. Exposure involves writing narratives of the rape in detail and reading the narratives aloud in session and for homework. Clients write about the meaning of the rape, and themes of safety, trust, power, esteem, and intimacy are addressed. Clients are provided basic education about feelings, given information about how self-statements affect emotions, and are encouraged to identify stuck points, that is, inadequately processed emotions about the trauma in their narratives. Specific cognitive strategies are used to challenge maladaptive beliefs about the rape, for example, self-blame, helping the victim accommodate her experience in a healthy manner and maintain a balanced and realistic perception of the world. The role of the therapist is to ask questions in order to elicit the meaning, function, usefulness, and consequences of the patient's beliefs. It is up to the client to ultimately decide whether to reject, modify, or maintain personal beliefs by weighing the emotional and behavioral consequences. It is never the intent of a therapist to exhort or cajole the patient to adopt a new set of beliefs, And like what many people think, cognitive therapy is not the substitution of negative beliefs by positive ones. Some techniques and tools used in CPT are journaling, nightmare exposure and rescripting, relaxed breathing, playing the script until the end, unraveling cognitive distortions, progressive muscle relaxation, cognitive restructuring, introspective exposure and response prevention. This case study describes the treatment of a female psychology graduate student referred to as Mary, who presented with complaints of mild symptoms of depression and a lack of motivation. It was revealed that Mary had been sexually assaulted 4 years before presenting for therapy and was diagnosed with depression and post-traumatic stress disorder. Because of the timing of the symptom onset and the nature of her symptomatology, it is likely that she was experiencing a form of vicarious traumatization that further complicated her own difficulties. The primary purpose of the current article is to draw attention to the importance of self-care for mental health professionals and to provide recommendations for the promotion of well-being in professionals working with trauma survivors. The secondary aim of the current study is to discuss Mary's progress through 12 sessions of manualized cognitive processing therapy for rape victims as further support its efficacy. And the link for this case study is right below the paragraph. In this case study, Jocelyn Rowley, a 20-year-old single woman, was a sophomore at a Midwestern university. She had always been a good student, but her grades had fallen recently and she was having trouble studying. Her academic difficulties, coupled with some problems with relationships and with sleeping, had finally led Jocelyn to see a therapist for the first time. Most of Jocelyn's symptoms had begun about 2 months before she visited the university's counseling service. Since then, she had been having nightmares almost every night about unfamiliar men in dark clothing trying to harm her. She was not having trouble falling asleep, but she was trying to stay awake to avoid the nightmares. Jocelyn also reported problems with interpersonal relationships. After several sessions, Jocelyn mentioned to her therapist that she had been raped by the teaching assistant in her English literature course. The rape occurred 2 months before she entered therapy. Cognitive therapy and anger management training helped Jocelyn improve her communication skills with others, and she was able to complete school, have a successful career, regain closeness with her family and friends, and with a little additional help from therapy, form an intimate and lasting relationship with a loving partner. And the link for this case is right at the bottom. As in all things, there are advantages or disadvantages or strengths or weaknesses. Some advantages of CPT are that it can be as effective as medication in treating some mental health disorders and may be helpful in cases where medication alone has not worked. It can be completed in a relatively short period of time compared to other talking therapies. Focuses on retraining your thoughts and altering your behaviors in order to make changes to how you feel. The highly structured nature of CPT means it can be provided in different formats, including in groups, self-help books, and computer programs. Skills you learn in CPT are useful, practical, and helpful strategies that can be incorporated into everyday life to help you cope better with future stresses and difficulties even after the treatment has finished. The disadvantages of CPT are that the client would need to commit themselves to the process. A therapist can help and advise, but the therapist cannot make the client's problems go away without cooperation. Attending regular CPT sessions and carrying out any extra work between sessions can take up a lot of time. Due to structured nature of CPT, it may not be suitable for people with more complex mental health needs or learning difficulties, as CPT can involve confronting your emotions and anxieties. A person may experience initial periods where they are more anxious or emotionally uncomfortable. Some critics argue that because CPT only addresses current problems and focuses on specific issues, it does not address the possible underlying causes of mental health conditions, such as an unhappy childhood. CPT focuses on the individual's capacity to change themselves, their thoughts, feelings, and behaviors, and does not address wider problems in systems or families that often have a significant impact on an individual's health and well-being. CPT is compatible with the Christian worldview. Similar to CPT, spiritually integrated cognitive processing therapy, SICPT, is designed for individuals experiencing PTSD across the spectrum of severity from mild to severe symptom presentations. CICPT also encourages clients to access support from or immersion in a faith community, which can help with recovery and integration. And in addition to identifying spiritual resources to aid in recovery, spiritual struggles, which are part of moral issues, are specifically normalized and addressed in treatment. Spiritual struggles might include feeling angry at God for allowing this to happen, feeling punished by God, questioning God's love in one's religious faith, feeling abandoned by God or one's faith community, or a complete loss of faith as a result of severely traumatic experiences. And it's good to note, and we need to note, that given that SICPT makes explicit use of a patient's spiritual religious beliefs, this intervention is only appropriate for individuals who identify as spiritual or religious. At the bottom, there is a summary session content outline of SICPT, and it's also a guidebook with a link. SICPT is delivered in 12 sessions over 6 to 12 weeks. Each session is 50 to 60 minutes in length and follows a similar format. On the slide prior to this one, I did provide you with a link to a session outline and guidebook, which can help you out tremendously. And also, if you would compare this guidebook to the guidebook that I supplied a link to on the assessment page, you will notice there is definitely similarities. Like I said, the only thing given with this particular model is that it makes explicit use of a patient's spiritual and religious beliefs. Therefore, this intervention is only appropriate for individuals who identify as spiritual or religious. On this slide, I have listed some resources for learning CPT. Thank you for listening. I chose this topic for both personal and professional reasons. On a personal level, my sister Carla was raped and brutally beaten by three men who left her for dead and threw her into a dumpster. A homeless woman located her body and contacted law enforcement. She was re-victimized by the ER doctor, law enforcement, and the courts. Shortly after her trial, she committed suicide. It has been such a loss. It was difficult observing her decline, going from being a lovely social butterfly to isolating herself like a nun and later succumbing to suicide. She was 20 years old. On a professional level, I want to become an emergency room advocate on call in local hospitals for survivors of domestic violence and sexual assault.